Now, let's think about it for a moment. Is our patients are generally systemically sicker. They're not looking after themselves as much as should do. Life is more stressful. Hello, everybody, and welcome to the next episode of the Dental Implant Podcast. I don't know why. There was part of me that really felt like saying, previously on the Dental Implant Podcast. And I think part of that probably comes from the fact that myself and my wife have been watching 24 recently. So I've got it in my head, previously on 24, previously on the Dental Implant Podcast. So thank you for joining me again. It is a Sunday morning. I've just got back from the gym not too long ago, which is why I'm looking a little bit rough around the edges. But let's face it, you guys aren't here for my pretty face, although some of you may be. Well, if you're listening to this as opposed to watching it, then obviously you're not. But go on, Joe. Right, guys, let me give you a little bit more information. As always, I've got my notes ready. So if I'm looking over to one side, I'm just doing it to refresh my memory. So you guys are absolutely fantastic. I've got people listening from all over the world, and it's really quite an honor. So if there's anything that you guys particularly want to know about, reach out to me. Find me on Facebook, search for the Dental Implant Podcast. Look me up on YouTube, surprisingly, the Dental Implant Podcast. And, you know, just let's chat. Let's open conversations. You know, let's see what you guys want to know about. So what am I going to discuss today? Something I've alluded to before, vitamin D and cholesterol, hypercholesterolemia. So let's get started. Bad cholesterol, LDL, low density lipoprotein, whatever you want to call it. I may interchange those terms. When I'm referring to good cholesterol, obviously I'm talking about HDL, high density lipoproteins. So let's see how this all interplays together, okay? So what does low density lipoproteins, what does LDL actually do? It increases the activity and differentiation of osteoclasts. Those are the cells involved in bone destruction, effectively. So what bad cholesterol does is it actually alters your bone metabolism for the worst. Firstly, it suppresses osteoblasts, the cells which start to depose the osteoid matrix. And secondly, it upregulates the osteoclasts. So that's one of the reasons why if your cholesterol is raised, particularly your LDL is raised and it's not in balance, it does actually impact bone density. So the other thing that we know as well is elevated serum LDL. It increases the inflammatory response to bacteria as well. So let's put aside the healing process for a moment. Is if your LDL cholesterol is raised, you may find that periodontally you're more susceptible to problems because you have an elevated inflammatory response. Now, a lot of patients who come in to see us who want to have implants have had periodontal issues before in the past. And what do we know? That as long as the periodontal issues are controlled, we can go and we can place implants. That is not a problem at all. But then the argument then becomes, should we then be looking at their cholesterol profile and making recommendations either directly through their GP or through whatever health service really, that to make lifestyle changes to improve their LDL cholesterol profile? Yeah, I mean, why not? We're looking after these patients' best interest. You know, I was chatting with Bill Schaefer a few podcasts ago, and I'd said to him that I'd noticed poorer bone quality coming in. A few weeks ago as well, Bill and I had a little bit of a chat. He's noticed an increase in early failures as well. Now, let's think about it for a moment. Is our patients are generally systemically sicker. They're not looking after themselves as much as should do. Life is more stressful. That elevates cortisol levels, which then has an impact on bone metabolism as well. I'm not going into that this episode. I will go into that another episode for you. What I'm trying to do is I'm trying to give you a little bit of an indication that actually it's a little bit more complicated than bang, putting an implant, heals, and everything's absolutely fine. Okay? So LDL, it does actually increase the inflammatory response. So we need to do what we can to try to reduce and mitigate these risks for patients. Get their LDL cholesterol down and improve their overall profile, okay? So what happens is bone releases enzymes which are involved in oxidation of LDL, okay? So the bone leaches these enzymes outwards. That results in a reduction in bone mineral density. And that's one of the methods by which LDL cholesterol plays a role. So oxidative stress is important. Now, we've heard about antioxidant, and this, again, just goes to show it's another factor that is directly related to what we do. There are some supplements, I think particularly based out of, I think it's Canada, it might be the US and Canada, where it is a support system for patients who are having implants placed, and in there they have antioxidants. Me personally, if patients are coming in to see me and they want to know what they can do, and part of this is in my consent form as well, there's a great supplement from a guy called Mike Mahler, Mahler. This guy talks about hormone optimization, and one of the things that he does is he has a supplement range called Restorezyme, which is a systemic enzymes, and it's designed to reduce systemic inflammation. Now, what this won't do is it's not a magic bullet cure. So if you're not looking after yourself and if your diet's crap, then they're not really going to help. And in fact, talking about it, here it is. I take them myself, okay? And I recommend those to surgical patients. It's just part of the assessing the patient overall, okay? So bone leaches certain enzymes, reduces its density in response to low-density lipoproteins, okay? So it goes back to that thing, doesn't it, where, we're always told by doctors and everybody else, look after yourself, have a healthy diet, have a Mediterranean diet, exercise a certain amount. And we go, yeah, we wave it off and we're like, oh, yeah, it's fine, it's not a problem, a little bit of weight here and there is bad. Now, I'm fully respective of the fact that I am overweight myself, and I need to do something about that. The power is mine to do something about that. So I've improved my diet. I've joined the gym, which is why my hair's looking like a mess, why I'm looking like I got back from the gym about an hour ago, because I got back from the gym about an hour ago. Because the more I'm reading about this, the more I'm realizing that your cardiovascular health and your neuromusculature is not just important for cardiovascular health long-term and to avoid cancers and heart disease, but in terms of systemic metabolism, okay, healthy bones, healthy everything, it's really, really important. So that's one of the reasons why I'm back at the gym, because the more I'm studying this, the more I'm thinking to myself, wow, this is so impactful that if I'm going to be telling my patients to do this, I need to be doing it myself as well, okay? Yeah, so again, going back to that good quality diet again, one thing you may not realize is a lot of the olive oils that you get from supermarkets, they're actually blended. So the olive oil that I use myself personally, I get it directly from an Italian farm. And the reason why that's important is with these Mediterranean diets, it's particularly the olive oil, which is a very powerful antioxidant, but it has to be pure or compressed olive oil, not something that there's nothing on the supermarket shelves that I would classify as a good quality olive oil. That's why I get it direct from the source. Looking after yourself and a healthy diet. I think I've mentioned this before, the fruit and the veg that myself and my wife we get from a local farmer's market. We are very particular about the source of meat that we get. And again, I'll come on to that, I think, in a later episode, the reason why I won't have any meat that's from the supermarket. There is a reason for that, okay? So next thing, increased LDL, oxidized LDL, it suppresses osteoblast function. It suppresses osteoblast health, and it suppresses osteoblast differentiation. So what that means, the bone-forming cells, they are fewer in number, they are weaker, and there are less recruitment of them. So on one hand, you have this elevated osteoclastic activity. On the other hand, you have this depressed osteoblastic activity. And it's that imbalance which has a big impact on bone metabolism. Because quite often these are cascade effects. Normally you'll find you're not going to get this, you're not going to get an elevation in something without a suppression in the other. So that's why quite often you'll find that very much working in combination like that. So what we think as well, so the reason why it's called good cholesterol, HDL, high density lipoprotein. The reason why it's that way around is because what we know to be true is HDL, it appears to interrupt the cascade events leading to the oxidation of low density lipoprotein. So we spoke a few moments ago about how bone releases enzymes, and in doing so reduces bone mineral density, and that's in response to the presence of low density lipoproteins. Now, HDL will actually interfere with that cascade. That's why when you speak to somebody, they talk about ratios of HDL to LDL. And there's a lot of medical colleagues out there where they don't mind your overall cholesterol being elevated as long as those proportions are correct. If those proportions are out of kilter, that's when you generally tend to find you're having more issues. Now let's think about it for a second. A lot of the patients who are coming in to see us, they will have undiagnosed hypercholesterol issues. They won't know what their ratios are, and we're doing intervention surgery on them. You know, we are doing bone grafting for them. We're placing implants for them. We're charging these patients a lot of money. Should we be taking blood tests first and having corrective work done first for a better outcome for our patients? That is something that you guys need to decide for yourselves. Okay, I can't tell you what to do. So high density lipoprotein is basically a bone cell protector. It protects a bone cell. Okay. What happens when the LDL is elevated? It reduces bone metabolism, but not only do you get a reduction in bone mineral density, you get an increase in the amount of fat in a bone within the bony compartment as well. So Professor Brannemark, if you don't know who Professor Brannemark is, I don't know why you're listening to this podcast, because you obviously don't place implants. The godfather of implants, forget godfather, the father of implants, the absolute reason why we're doing them today, okay, is one of the things he used to say is yellow bone scares me. And quite often if he was going to do surgery and he opened it up and he found yellow bone, oh, what's the yellow in bone? It's fat. If you open up an upper six position and the bone's really soft and you're drilling and you're looking at it and it's all yellow, it's because it's fatty. It's not true bone. And you'll notice when you're doing your osteotomy, when it bleeds, if you've got really good surgical light and good magnification, I use 2.8 magnification and overhead surgical light, you'll see like these little oil droplets on top of the blood. Why is that? That's fat. Okay, so that is one of the reasons why you can get an increased fatty space. Okay, so just be aware of that. So that fat obviously inhibits osseointegration. How does it interfere with osseointegration? Because it's not bone. And we know that in those cases, the osteoclastic activity is high and the osteoblastic activity is low. Okay. Federico et al., they showed that an elevated total cholesterol increased the risk of failure of bone grafting by 7.5 times. You are 7.5 times more likely to have issues with bone grafting when your LDL cholesterol and total cholesterol is raised. Okay, so let me ask you what I asked you a few minutes ago is, are there certain patients that we should be doing blood tests on and having corrective work done on before we start doing anything along these lines? Okay, so cholesterol is actually, HDL, it's actually converted to a pre-vitamin D3. Okay, so in the correct cascade, it's actually helpful. It's needed to synthesize vitamin D3. Okay, now vitamin D3 is really, really important, particularly people with my skin tone during the winter when you've got very weak sun outside. Generally tend to find your vitamin D levels are extremely low. Now, vitamin D is related to a healthy immune system, healthy bone metabolism. Without it, you're going to have pretty serious issues. And there are a lot of people out there walking around with undiagnosed vitamin D issues, okay? So what happens is after binding to the vitamin D, there's a carrier which then transports this pre-vitamin D hormone to the liver, okay? And that is then converted into hydroxyvitamin D3, okay? Now, the issue that you have is if you have a fatty liver, okay, or you have liver dysfunction, that conversion is going to be interrupted somewhat, okay? So what does that That goes back to the healthy lifestyle we were talking about before. If patients are coming in to see us and they are overweight, their body fat percentage is high, they're not looking after themselves, they're not exercising, they're not healing properly, and they have liver issues as a result, then their vitamin D is going to be suppressed even further. Supplementation with vitamin D is very easy to do, and it's very predictable to do as well. Again, should we be looking to do these types of blood tests prior to actually undertaking any treatment for grafting or for implant placement? Now, you may be thinking to yourself, single implant, I'm not as bothered. What about if you're doing a full mouth? What if you're doing about a full arch? What if you're doing about a quadrant? For the sake of a blood test, it may be worth it, okay? So I'm not sure how to pronounce this name, but I have read it. Dvorak et al. Demonstrated that a vitamin D deficiency has a negative impact on cortical peri-implant bone regeneration. Okay, so what does that mean? You put the implant in. If your vitamin D is not appropriate, not high enough, the seal of the cortical plate around the neck of the implant is compromised right from the start. Now, remember when I spoke in the episode about super osseointegration? Well, can that help in these instances? Yes, absolutely it can. It's just another cog in the wheel. That doesn't mean that you can ignore all the vitamin D issues. That just means with super osseointegration and treating implants before they go in place, you're just starting to tip the balance in our favor, okay? Vitamin D, really important. Liver health, really important. And you see how all these things are starting to interlink together, okay? So vitamin D deficiency has also been implicated in numerous allergic disorders, and we know it's involved in the immune system as well. When people say, to keep your immune system healthy, you need to take vitamin C, vitamin D is more important than vitamin C, full stop. Okay, there's no argument around that. So Sabetta et al. In 2010 conducted a cohort study that showed that vitamin D concentrations of above 38 nanograms per mil were associated with a twofold decrease in upper respiratory tract infections. Okay, so you need a high level of vitamin D to help protect your body and your immune system, okay? So vitamin D deficiency has also been implicated in other diseases like, it's linked to diabetes. The theory is that it impairs insulin sensitivity, okay? Now, if you think about it, is which of the groups in the UK more likely to suffer with diabetes? It's the darker skinned population. Okay, population such as myself. Why? Because my skin tone is designed for a much higher dose of sunshine, which I'm not getting, so my vitamin D is low. So if a lot of these people are going out and they don't have enough vitamin D, and they're not eating well, not looking after themselves particularly well, that vitamin D deficiency is not helping them. It's pushing them towards diabetic type tendencies and diabetes. And so we need to understand that it's all, this is all linked together. We know that diabetes interferes with healing, with wound healing. Is it possible that it's also directly linked to vitamin D and diabetes at the same time? I don't know. I don't have these answers. I'm just telling you that, I'm trying to sift through the information and piece together one thing at a time, okay? We know that vitamin D deficiency is related to high blood pressure, cardiovascular diseases, certain cancers. High serum vitamin D is really important for bone metabolism, okay? I had a patient recently where, my fault, I didn't do any blood tests on, and we just told him to start taking vitamin D before we did any treatment, and he didn't. And we did a dual arch for him, and out of 8 to 10 implants, I think he lost 6 of them. We replaced them, he lost them again. We replaced them another time, he lost them again. We did a blood test and found out that he wasn't taking our advice, not taking vitamin D, and his vitamin D was it was virtually non-existent. And this is one of the reasons why he was having issues. So it's really important that you stress to the patients, particularly if you're going to do blood tests, look, this is an issue, this needs correcting first, and then we can do your treatment afterwards, okay? So vitamin D supplementation also reduces LDL cholesterol. Can you see how this is all starting to tie in together now? Yeah. And as I said, there is a potential link between low vitamin D and insulin sensitivity as well. So look, guys, this is what I'm trying to get to. There's no black and white answers. And as I've said in a previous podcast as well, you can't isolate 100% of factors, because there's too many factors to take into consideration. So what you start to do is you start to read around the topic and start to build up an idea of, systemically what should be going on. Systemic problems are grossly underrated when it comes to implants. Why? Because we think just in terms of 3D placement of the implants, and we don't think enough about the systemic issues. We don't think enough about the biology. If you want to get some really good data, forget the dental journals, forget the dental implant journals, look at the orthopedic journals, look at the osteoimmunology journals, the osteoimmunology textbooks. They have got so much information there that they've known for 10, 15, 20 years. And at the moment, we're just like, oh, wow, this plays a role. You know what? Follow what the orthopedic surgeons are doing, because they are doing much more invasive, much bigger surgery. They've had these issues for a long time, okay? From my perspective, dental implants are nothing special, okay? It's just orthopedic surgery in a patient's mouth. That's what it comes down to. So if it's orthopedics in a patient's mouth, maybe the orthopedic surgeons know something that we don't. This is why reading around subjects is really important as well, okay? So I just want to summarize again for you quickly. So if you've got elevated low-density lipoproteins, what does that do is it increases the osteoclastic activity, it reduces the osteoblastic activity. High-density lipoprotein will interfere with that cascade and start to tip the balance back in our favor. We also know that elevated total cholesterol is linked to failures in bone grafting, 7.5 times more likely to have issues. So not only do you want your cholesterol down, but you want the ratios to be correct as well, okay? Healthy lifestyle is important, good source of foods, and particularly olive oil. Don't buy the crap from the supermarkets. Vitamin D and cholesterol, again, they're linked. If you've got a fatty liver because you're not looking after yourself, you're not doing enough cardio work, you've got a bit of a gut like me, that will play a role. And then that then interferes with insulin sensitivity and vitamin D, and which will then, if you've got a low vitamin D level, then that will again reduce your bone metabolism. It all just starts to link together, okay? So let's start to think a little bit more laterally. Let's start to look at patients as a whole. When patients are walking in through the door wanting to have surgery done, I'm not telling you to make judgments on your patients, But if you've got somebody who comes in who they're quite clearly not looking after themselves so well, you may want to consider taking blood tests for them first to make sure you're not trying to ice skate uphill before you've even started any surgical work for them. So thank you guys very much for listening. I will aim to do another podcast as soon as I can for you guys. If there's anything in particular you want to know about, I've got loads of topics already written down. If there's anything you want to know about sooner rather than later, just let me know. Very happy to discuss that with you. Please ask your colleagues who may be interested in listening to give us a listen and share and promote, and that would be very much appreciated. And I will speak to you guys later. Bye.